Hey guys, Chris here from Lifeline EMS Training. Today I wanted to go over with you pacing 101. So the basics of pacing. So how to speed stuff up that's going slow, right? So what do you need? Pacing is a little different than synchronized cardioversion and defibrillation. You need the electrodes and you need your defib pads. The electrodes are what sense the underlying rhythm, and the pads are what deliver the energy to upregulate the heart rate by pacing it. So delivering that energy to pace the heart faster. So you need electrodes and you need the pads. Where do you put them? Well, the electrodes, I recommend putting them on the core or the trunk because the person may be starting to jerk when they're getting paced and it will hurt. It will also create motion. And what you don't want them to do is to pull the limb leads off, the ones that are sensing the underlying rhythm. And we'll talk about why that's important here in a second. So I recommend putting them on the trunk. Wherever you put your pads, there's anterior lateral, like we've talked about in some other videos. There's the anterior posterior, and we'll hit on those here in a second. If you're going to put the limb leads on the limb, I recommend you taking some tape or an ace wrap and wrapping them on there once they're connected with the wire, because you don't want them to pop off. So wherever you put those defib pads, like we said, there's the anterior lateral, there's the anterior posterior version 1, which is the normal anterior, and then you put the lateral lead left of the patient's spine, or you have anterior posterior version 2, which is the anterior lead is to the left of the patient's left of the mediastinum, and then the lateral lead is posterior or the left of the patient's spine. We are delivering external energy to create a depolarization at the rate that we pick. So we're trying to overtake the normal conduction of the heart in order to speed it up using our external energy source. It's very much like a TENS unit. If you've ever used one, seen one, all TENS units are pads delivering a small amount of energy to overtake the muscle to create contraction in different patterns to help with healing, stretching, fatigue, etc. But here's an example of a TENS unit. So the pads here impulsing that forearm muscle, and they've taken over its electrical function. So they're controlling it. That's what pacing is. We're controlling the heart. So what do we pace? We pace slow rhythms. We try and pace them up or speed them up. And it's for patients that are unstable. So when we talk about stability, we're talking about a person that has poor cardiac output or poor perfusion. We've talked about that in a bunch of other videos prior. Because the person doesn't have good perfusion, squirting a drug like atropine is not going to circulate well. And a medication like atropine requires the dose to get to the heart tissue, those nodes, to help speed them up. And if it gets diluted or doesn't make it there, you can actually create rebound bradycardia, which we talked about in the atropine video under the ACLS medication series. So we look for bradycardic rhythms where they have poor cardiac output. So here's a person who's bradycardic, has a low end tidal, definitely sub 35. Here's a bad pressure and a low amplitude pulse ox plus. So this definitely has a poor cardiac output profile to it. So what are the steps to pace? Well, it's actually pretty easy. Remember, you put the electrodes on, so they're sensing the underlying rhythm. And this is the LifePak 35. So you hit the therapy box, hit pacing, you pick your rate. So most of them default between 60 and 80, which is what the OCOR guidelines recommend. You make sure that it's marking or sensing the underlying rhythm, and then you start going up in milliamps. And what's happening is you said, I want to pace you at 60. As you go up in milliamps, the energy you're delivering, you're trying to create that capture, that mechanical capture, so that you're overtaking the depolarization of the heart at the rate you've picked, in this case, 60 beats a minute. And you're looking for a QRS complex after your pacer spike. So this is your energy being delivered here. This is your depolarization you're generating in the heart. This is a Y to bizarre, so you've captured the ventricles. And we're doing a demand at a rate of 60, and we captured 60 milliamps. That's what we're looking for. And we're looking for the end tidal to come up, blood pressure to come up, because we've increased heart rate. Heart rate times stroke volume is cardiac output. So to recap, what we're looking for is that electromechanical capture. So we have electrical capture the QRS after every pacemaker spike. And we also have mechanical capture. This is where we feel the patient's carotid pulse, femoral pulse, radial pulse. But in this instance, we can tell because we have a pulse ox pleth for every QRS. So we have distal perfusion for every QRS. So we have mechanical capture. And we'll talk about a phenomenon where you can get electrical capture, but not mechanical capture. And it can actually be deceiving. This is the phenomenon I was telling you about, where you can have electrical capture, but not mechanical capture. Notice QRS after every pacemaker spike, but we don't have a pulse ox pleth for every QRS. We've delivered just enough electricity to have kind of this washing over the heart. So we have electrical activity. It's kind of like PVCs that don't perfuse, right? We have electrical activity, but we don't have capture of the mechanical function of the muscle. So we need to, in this instance, if we have this, continue to go up in our milliamps so we get mechanical capture as well. So we're delivering enough energy to capture the muscle function, just like that TENS unit you saw a second ago. So demand, these are demand pacers, meaning they're always sensing the underlying rhythm. If the underlying rhythm goes faster than the 60, in this case, beats per minute, the pacer will kick off. It's always sensing. So if the patient's underlying heart rate is faster than 60, the pacer kicks off. If it slows down again, the pacer will kick back on. And it uses the electrodes to sense that. So it's constantly watching. So it's demand. It's as needed. The patient's heart goes 60.5 beats, it kicks off, right? There's also fixed. So fixed happens under two things. The patient A needs to be fixed paced at a high rate, and you want the pacemaker to continually be the source of mechanical generation of action of the heart. Or if one of those limb leads pops off, the monitor defaults to fixed pacing. The caveat being it's not looking at the underlying rhythm, and you can create an R on T situation where the person's underlying rhythm is going and a pacer spike is hitting. And because their two aren't being monitored, it's firing blindly, and you could hit them on that T wave and cause a pacer-induced VFib. But fixed pacing is the default if the limb lead falls off, or it's a mode you pick because the patient warrants that. So how about patients that have internal pacemakers? So internal pacemakers are implanted up here, floated through the vasculature, down through the right atrium, and then implanted. And there's a bunch of different types of leads. They can either be seated, corkscrewed. They have like an arrow essentially where it goes in, they twist it halfway, and it implants in the cardiac tissue, and that's how the energy is delivered. And those internal pacemakers, they float that in, and they could be dual chamber, single chamber, so they could have a atrial generating pacemaker, a ventricular generating pacemaker. They can have an AV pacemaker where both of them are working. And so what does that look like? What that looks like here is a pacemaker spike with the QRS afterwards. This would be a single chamber ventricular pacer internally. So the patient's pacer is firing or generating this rhythm here. Do an EKG, you see these pacer spikes, and these pacer spikes are that electrical impulse that's coming from that little module that was implanted in the left upper chest of that patient. Energy is going down and triggering the depolarization of the heart cells. You can have dual chamber, right? Like we talked about. So here's two pacemaker spikes, one here, and then one right before this Y bizarre complex. This is an AV pacer. So the nicety to this one is it creates an atrial and ventricular contraction. And those atrial and ventricular contractions get you the atrial kick. So it's a little bit more of an efficient cardiac output. Here you have the atrial pacemaker spike, atrial depolarization, ventricular pacemaker spike, ventricular depolarization. So that's a dual chamber pacer. We're going to go over an example of pacing here. So we have Brian playing the patient Mark. He's hooked up. We have the electrodes on his trunk. We have the pads on the outside. They would actually be on the patient. We have them here so you can see where they are. So he's groggy. He's altered. He's bradycardic, hypotensive, low end tidal, low pulse ox, pleth. So he's that poor perfusion. He's kind of groggy and out of it. So pads, electrodes. So we're going to hit our pacer. We're going to go down to start pacing. Go to our output. All right, sir, we're starting to get you here. All right, so we have a QRS after every pacer spike. That's good. We have pulse ox pleth that matches. Let's check our pulse. Our pulse matches. Good deal. Drop our pacer. Grab another pressure. All right, sir, we're gonna give you some medicine, okay?
Yeah.
All right, so we've captured him at 70 beats, 60 milliamps. Grabbing another pressure here. End tidal starting to climb. Perfusion's coming up, so we're doing good. He's starting to get paced, as you see with the twitching. So we'll give him a little bit of ketamine, fentanyl. He had a soft pressure before, so we'll hold off on the Versed because we don't want to tank him again. Give him some fluid, right? Because cardiac output, heart rate times stroke volume. So that's an example of pacing. So that's a quick review on Pacing 101. And as always, if you have any questions, hit us up at info@lifelineemstraining.com, and we hope you have a great day.